So who are the candidates for fetal surgery? There are some that have established benefit, and then there are some that there's probable benefit. If you talk about established benefit, everybody agrees, I think, that for twin-twin transfusion syndrome, laser therapy is very useful. We have data that is being generated, and what I'm showing you initially are those with level 1 evidence, i.e. a randomized controlled trial. For congenital diaphragmatic hernia, myelomeningocele, I'll talk about that. Aortic or pulmonary outflow obstruction, we think that it's of benefit there. Amniotic band release, I'm going to show you some images of that. Lung masses, teratoma, bladder outlet obstruction, exit procedures for predictable cardiorespiratory compromise, and then one that we are starting to look into, which is gene and cell therapy. So let's start with twins. If the morula splits at less than 4 days after fertilization, you will have identical twins who have 2 completely separate sacs, 2 completely separate placentas, and they are called dichorionic and are not at risk. So you can have completely separate identical twins. If it splits between 4 and 8 days, then we're going to end up with babies that share a placenta, and this is a real high-risk situation and what I want to talk about. Between 8 and 14 days, we get both babies in the same sac. Very dangerous situation because they can wrap each other's cords around each other and strangle, and you can lose one or both of those babies. And after 14 days, we start getting conjoined twins. So there is a hidden mortality. If you have a single placenta and twins, it is a much, much higher risk pregnancy than if you have 2 placentas with twins. So all monochorionic placentas, all of them have connections on the surface between the 2 babies. 15 to 20% of the time, something goes wrong, and there's a net transfusion or there's a net pressure differential. There's something that's going on that creates a situation of hypertension in one baby, renal shutdown, and hypervolemia, cardiac failure in the other baby. We normally call the baby going into heart failure the recipient, and we call the baby that is going into hypertension and shutting down its kidneys the donor. And what happens with the donor is that it is trying to protect its brain, its adrenals, its heart, and so it shuts down all non-essential organs. It stops peeing. It continues to drink all the fluid in the sac, so the membranes come closer and closer, and ultimately the baby's vacuum packed up against the wall of the uterus, and it's called a stuck twin. The other baby's getting this additional fluid. It goes into heart failure. It's peeing out as much as it can. It fills up its sac, and it's in this huge swimming pool. And that baby, it's in the polyhydramniotic sac. Okay, so here's a depiction of what that looks like. We start off, and then things start going wrong. The baby on the right, watch its bladder. It gets smaller. Watch the bladder on the baby on the left. It gets bigger. There's more fluid in that sac. Shuts down, and that baby is now stuck up against the wall of the uterus. This is advanced twin-twin. How do we treat it? We put a scope inside, we identify the connections on the placental surface, and then we put a laser in and we shut those down. And I'm not going to tell you too much more detail about the different types of connections, but you can see this is essentially how it's done. Looks very easy. The diagnostic criteria are it's diagnosed with ultrasound. And you can see on these images, you can see the polyhydramnios. That's all that black fluid around the baby that's in the big sac. And you can see the stuck twin up there in the left. That baby is sitting up there against gravity. So that tells you that something's holding it up there. Otherwise, it would drop down to the bottom like the other one. And then you can see the big bladder at the polyuria. You can see that kid lying on its back with a huge, big, full bladder. And here's what it looks like inside. So you can see here's this stuck baby, the membrane's stuck around it. And now we're going to go look at the placental surface. There's the little face, the membrane's stuck around it. Okay, here we're looking at the surface of the placenta, and we're looking at the connection. So you can see Here are blood vessels. That's a normal cotyledon. There's an artery and a vein supplying that, so we're not going to touch that one. There you can see the folded back membrane. That's called the membranous equator. Here you can see more blood vessels. You don't want to touch them. They bleed, and that can be disastrous because then you can't see anything to try and stop them from bleeding. But now you're going to see an abnormal connection. So basically we go in and we look for all these vessels along the entire placental equator, and we find ones where this one, watch this one. So we go up there, we look, now we follow it. It should stop there, but it doesn't. It carries on and goes to the other cord. There's the other cord insertion. So clearly that is one that needs to go away. And now you'll see a little red dot come along. And that tells us that's where the laser's going to burn, and then bam, we just burn the vessel and the connection goes away, and we do that all the way across the placenta. All right, so that's twin-twin transfusion-related laser, but we can also use the laser to do other things. Now I'm going to talk about spina bifida. Spina bifida is, at least in the United States, responsible for about 1,400 to 1,500 infants who are born annually with a meningomyelocele. Basically, at about 24 to 28 days after conception, the neural tube should close completely. In some cases, in that time period, the neural tube does not close and it's left open. There are two reasons why it can be really damaging. One is that you get the leakage of the spinal fluid, and that creates a low pressure area at the back of the head. There is a hindbrain herniation that goes into the foramen magnum, closing off the fourth ventricle. You get a buildup of pressure and ventriculomegaly, and these kids are at a much higher risk for hydrocephalus. A lot of them, 90% or more, if you do nothing, will need a shunt. The second thing is that you have exposed nerves that can now be damaged by fluid in the amniotic cavity, meconium, and by trauma. As the baby moves around, it's rubbing these exposed nerve fibers and spinal cord against the wall of the uterus. So you've got the original lesion, which is the first hit, and then you've got a second hit, which is something that we can perhaps intervene on and stop the exposure and the trauma. And in that way, you can take a baby that would otherwise be paralyzed and have that child born with the ability to independently walk. And you can also reduce from about 90+% to around 40 or so % the need for a shunt. These are huge advantages. This was actually shown in a large randomized controlled trial that has become the kind of gold standard now when talking about this condition, the MOMS trial. And what they showed is that you can reduce by half the number of kids who need a shunt, and you can increase by 100% the number of kids that are walking independently. And these are two very important outcomes. So what you're looking at here is the mother's belly is opened. We have lifted her uterus out through the incision, and then we've made a huge hole in her uterus. You can see that. That's about 14 centimeters in size. It's stapled. The membranes are stapled. We bring the baby's spine up into that hole. You can see the sac there. Then the neurosurgeon comes along and will first we'll give the baby some anesthesia. There's some fentanyl, some atropine, and some vecuronium in there. The baby is, of course, getting the same anesthetic gases as the mother. So this is not done under spinal. This is done under general. And then the neurosurgeon will do the standard neurosurgical repair. And then we close up the uterus. But this woman is now left with a large scar in the active portion of the uterus. And that is a real risk for rupture of the uterus, and will basically commit her to have a cesarean section for this pregnancy and every other future pregnancy. Okay. Is that really what we want to do in a low resource environment? And the answer is no. Is that really what we want to do in any resource environment? The answer is probably no too. The paper, the number one paper at our National Congress this year was on the long-term effects on the mother of fetal surgery. 11% of patients who've had fetal surgery like this rupture their uterus during a subsequent pregnancy. That can be life-threatening both for the baby and the mother. So, is there a better way to do it? And the answer obviously is yes, otherwise I wouldn't be standing here. And we have a number of different things that we pioneered here at Texas Children's in order to protect the membranes. And so what we end up is seeing this. 2 ports through which we put the instruments, we operate and do the repair. We were the first site in the United States to do this, the first site in the world to pioneer this technique. And we also got criticized for doing it. But I will have to say that Mr. Wallace, the Department of Surgery, the Department of Neurosurgery, Bill Whitehead, who is in the middle of the screen there, believed in us and supported us. And I think this is absolutely crucial. The teamwork, the collaboration, the institutional support, and the ethical framework. As long as you are doing the right thing in the right way, it's very reasonable and even an obligation to innovate when you live and work in a system like we have. So we continued to innovate this technique. And what we do is we go in with these small instruments, we isolate the placode, we dissect that placode, we allow it to drop down, we then cover the placode with a dural replacement material, we create muscle flaps, suture them on top of the material, and then we close the skin. And here you can see a procedure being done. You can see the placode in the middle of that sac. You can see here a microscopic scissors with a bovie diathermy. We open the sac. This is all done in a very different technique to standard laparoscopy. Remember, standard laparoscopy has one camera and 2 instruments that are held by the same person. In this technique, you've got one person controlling the camera and the grasper, and the other person controlling the operating instrument. So it requires a huge amount of practice and training to get this technique right. But we believe that 2 ports is better than 3. Making 2 holes in the membranes is a lot better than 3. So here you can see we've cut the muscle flaps. Here goes the patch. This is a piece of bovine collagen. We then suture those flaps of muscle over the top. You can see that flap of muscle is covered by dura underneath. And once we have closed that over the top, the second layer, we close the skin. These are extracorporeally tied knots that we slide down the thread, and it goes in one direction. It won't come backwards. It's like a ziplock. And that will slowly pull the muscle layer together. And then we will close the skin over that. And you have a 3-layer watertight closure. This is what the baby's backs look like. Those marks on the side are relaxing incisions. Often there's not enough skin to close the entire lesion. So we will cut these lateral incisions down the baby's flank. Sometimes they heal completely like they do there. Other times they heal partially. But usually once the baby's born, they heal very, very quickly. Within 10 days, the skin's completely covering them. And there's one where we didn't have to cut relaxing incisions. But you can see you get a nice repair. And these children in our series, we've now done about 57 or 58 of these cases. Our results are as good as, if not better, than the MOMS trial. 50% of our patients so far have had a normal vaginal delivery. We offer a normal vaginal delivery. The only time they don't get a vaginal delivery is when they have an obstetric reason. Like the patient we delivered earlier this week was a breech baby. So we did a cesarean section for her at 39 weeks. The average gestational age of delivery for us now is between 37 and 38 weeks, with a median of 38 weeks, compared to 34 weeks for the mom's trial. So we have taken and none of these women require a cesarean section for future pregnancies. Now I'm going to talk about cardiac interventions. I'm a little worried because I've got a real cardiologist sitting in front of me, but he's promised not to correct me if I tell you some things that are wrong. There are some interventions that we can do for hyperplastic left heart syndrome. The most common cause of that is going to be an aortic stenosis. And often by the time that baby arrives here, that left ventricle is gone. If we can get it early enough, we can actually see a big left ventricle that's trying desperately to empty against an atretic or stenosed valve. If we can go in there and open up that valve and make it into a regurgitant valve, we can save that left ventricle to some extent, and it really makes a difference to the long-term life of that child to have two ventricle physiology instead of one. So what do? We stick a needle through the mother's belly, through the baby's chest, through the lung, through the left ventricle, run a wire up over that atretic valve, put a balloon in there and blow it open and hope for the best. Here you can see the balloon, and you can also see coming in here the needle. And it always amazes me how the heart continues to beat when you poke a big needle into it, but it does. And you'll see the needle come across here, the wire come across here. Dr. Henry Justino does that, one of our interventional cardiologists, and Dr. Atta Qureshi, they're fantastic. And you can see the wire go across, and in a minute you'll see the balloon blow up, bam, and now that valve is destroyed. It's opened up. And so that's one procedure. The other procedure is when you have hyperplastic left heart, but with an intact interatrial septum. And this is a life-threatening condition at birth, because when the baby's born, not only does it not have a left ventricle, but anything coming back into the left atrium has no way to get into the right atrium and right ventricle for circulation. So it becomes absolutely emergent to open up that septum. Well, what happens if we open up the septum beforehand? Well, then the kiddo can be born in a much more controlled circumstance and have the surgery and have the interventions done without a mad rush to the cath lab to try and emergently open the septum. So that's another procedure that we do. And after we've done it, basically we use a stent for an adult coronary artery procedure. So we will put a metal stent, and there you can see inside the fetal heart a little piece of metal, and it's just lovely to see that because you know that it's doing something. The bottom you can see the pulmonary vein and the change when you put that stent in, how it improves the flow. Miracles. So the reason I put this in is to show you one of these miracles. Okay, I'm going to tell you about this case. There are a lot of people in the room who may have heard about this case, but I think there are a lot of people who haven't, so I'm going to tell you about this case. This is a patient that came to us at around, I think, 26 weeks, and she had a baby with this problem, hyperplastic left with an intact interatrial septum. And we said we can put a stent in, and we did put a stent in, and then the baby died in utero. And I'm going to show you. The baby's heart basically stopped. This particular day, I don't know what was different, but there was. And so we started doing cardiac compression on this baby's chest using the ultrasound. And we could see the baby lying on the mother's spine, and we could compress the mother's belly through the uterus with the ultrasound transducer. And that's what we're doing there. And I just want to show you first, I think this is one here, where you can see this. We did this for 45 minutes. Can you imagine that? That we were just not going to stop and not let this baby survive. I also injected this kid's heart 11 times, and then you can see the heartbeat started again. And the baby came back. But we were all very worried, what is going to happen to this child? No spontaneous heartbeat for around 40 minutes. Well, I'm happy to tell you that she survived. She is now, this picture on the right is now 2 years old. She's 5 years old, normal little girl running around. So that was an amazing, amazing case. The final thing I want to mention is that we have recently innovated that technique. One of the difficulties with the technique is trying to push a needle through a thickened atrial septum using ultrasound, because every time you push, everything moves and has to be changed and you lose your view. So now what we've done, and we did this for the first time ever, we put a thulium laser through the needle and use the laser. By firing the laser, you can see, you'll see the bubbles here. You can, without any force, without changing anything, watch, boom, laser goes through the atrium. You can slide the needle, you can place the stents. And then you get flow across the stent, and then you get a baby that does very well. Thank you very much for your attention.